Hello again. Good morning to you all. And especially as I told you that I will again come in the subsequent video in the regarding UPSC Combined Medical Services Paper 1 as well as Paper 2. I have already discussed. I think you have seen in the video Paper 1 and Paper 2 separate. Now today my video is Paper 1 and Paper 2 both, because the subsequent exam is coming, and uh, uh, you have to prepare well. So I will be discussing with you, and as I told you already, I am telling you before also, if you have any problem, if you have any doubt in any subject in the UPSC paper 1 or paper 2, please give in the group of Dr. Rajiv sir, or in my group in the as an individual. I will try to solve as far as practicable. And for now I am starting with the paper 1, and then I will discuss with the paper 2 also. Now today paper 1 paper 2 both will be discussed, and so it will be around the video of around the 30 to 40 minutes. And because the exam is also very near, and subsequent exam also up to 2026 has also been declared. The date has been not been came to me, but I think it is in the next year only. Next year around May June, nearby May June around. So I'm starting the paper 1 right now, and subsequently I will go to paper 2. So and one thing I will mention you again, I will be only discussing the question which are most frequently asked, because I will not discuss the question which are once or twice it is asked in the exam. Because in the UPSC there is one unique feature, that as you discuss the question, as you prepare for the question which are mostly asked, these questions are only asked. And so if you will discuss and if your concepts are clear, then there is a high percentage of chance that you will pass the UPSC exam in flying colors. So with this statement I am starting my question. uh, the first question in paper 1 goes like this. The presence of Now listen the question carefully, and as such I will giving you the answer, and then I will be telling you for 5 to 10 seconds to think about the answer, and then I will be giving you the answer with explanation. Now the question 1 comes like this. The presence of multiple cavities in the lungs with hematuria is suggestive of the following. I'm repeating the question. The presence of multiple cavities in the lungs with hematuria, multiple lungs and hematuria, is suggestive of what? Option A, Wegener's granulomatosis; B, tuberculosis; C, renal cell carcinoma; and D is the SLE. It's a very direct question and very easy question rather. Think for a while. I am giving you 5 to 10 seconds. I think I will give you only 5 to 6 seconds. You think for a while, and then I will be coming with the answer. Now, so the question which I asked, the presence of multiple cavities in the lungs with the hematuria is suggestive of. Actually, the answer is Wegener's granulomatosis, because all the other options, tuberculosis, renal cell carcinoma, and SLE, are very uncommon. The presentation of both, like multiple cavities and hematuria, because as you given as the above mentioned, in the condition, the multiple cavities in the lung are found in the tuberculosis, and hematuria is very uncommon there, and and the vaginal granulomatosis. And in the case of the renal cell carcinoma or hypernephroma, hematuria is present while the lung cavities are not found. And whereas in the SLE also, the both condition in the SLE, both condition are very uncommon, lung cavities and particularly lung cavities and hematuria is very uncommon in the SLE. And isolated pulmonary tuberculosis hematuria is not found, but in the present in the renal tuberculosis. So in the renal, finally in the vaginal granulomatosis, both conditions may be found, and hence it is the answer. And just I want to discuss about vaginal granulomatosis. It is a autoimmune disease, and most common presentation with the upper airway involvement, and typically presents with the epistaxis, renal clustering and sinusitis, hemoptysis, dyspnea, mucosal ulceration, and deafness due to the serious otitis media. And remember, this question is also come that in the renal granulomatosis, which type of deafness is found. So it is a mixed type of deafness in the PTA. When we do the PTA, that is testing of the eyes, testing of the ear, we found both conductive hearing loss as well as the sensory hearing loss. Secondly, the most common ocular abnormality is proptosis due to the inflammation of the retroorbital tissue, and migratory pulmonary infiltrates and nodules occur in the 50% of patients, and minority patient present with the glomerulonephritis. As we all know, proteinuria, hematuria, and red cell cast. Cast is red cell, and remember the patients are usually ANCA positive, C ANCA positive. Okay, so if it is, it can be also asked that which type of ANC is positive in the vaginal granulomatosis, C ANCA, P ANCA, or mixed, etc. So C ANCA is positive in the vaginal granulomatosis. So this is the first question, and second question I will be coming discussing with paper 2. I will be simultaneously discussing paper 1, paper 2 here. In this particular video, I will be concentrating on paper 1 and paper 2 simultaneously, so that you can have a good understanding and good concept about the question pattern and frequency of the question asking and which type of question is coming. So now, this is also a very easy question, and it is quite frequently it is asked 3 or 4 times. This is asked. The Framingham Heart Study. Thus, listen the question carefully. The Framingham Heart Study is the example of what? It is an example of case control study. Option A. Option B is the cohort study. Option C is the RCT, that is randomized control trial, and D is the cross-sectional study. So you think for the answer. I will give you only 5 seconds because this is a very easy question, and then I will be giving you the answer. So I think you have thought for the answer. Framingham Heart Study is the example of cohort study actually. So in the cohort study, we actually study the Framingham Heart Study, and apart from the Framingham Heart Study, we also studying Dolls and Hills prospective study on smoking and lung cancer. Apart from that, we also study the OCP and health. And in the case of the case control study, we study the adenocarcinoma of the vagina with thalidomide study and OCP of the thromboembolic disease. A combination of OCP and thromboembolic disease. We study in the case control study, and in the cohort study, Framingham Heart Study is been studied. So this is a very easy question, and this type of easy question is always being asked in the UPSC exam. And as I told you already also in my previous videos, unlike the NEET exam where they ask you a type of complicated question, conceptual complicated question, here the in the UPSC exam the question is easy and very direct question, conceptual direct question the UPSC examiner are being asked to you. And it is very easy to pass the exam if you have the clear concept and clear concept in your mind about the subject and about the understanding of the question. You can easily pass the exam. Now I have discussed the question paper 2. Now I am again coming to the paper 1. Now in paper 1, uh, now this is a very important question. It has been come in 1999 as well as 1982. Very old question, and again it has been repeated in the 2013, 18. This is a paper 1 medicine only. Now first listen the question and then you will think for the answer. I will give you about 10 seconds. Now beta blocker therapy, after beta blocker therapy, when the see this type of question when it is asked beta blocker therapy or NSAIDs or all this thing, beta blocker therapy, that means it is a cardiogenic, it is a cardioselective or non cardioselective. So whenever this type of question are asked, you will always remember that this type of question are taken into concern. The examiner set the question in that mind that they are asking the question on the both the view. So beta blocker therapy after acute MI is contraindicated in the following condition. In which condition beta blocker therapy is contraindicated? In the case where the patient suffers from the MI. This is the main question they are asking. So the option I am putting before you is heart failure, option A. B is orthostatic hypotension. C is the peptic ulcer disease, and D is the bronchial asthma. So you think for a while and then I will be giving you with the answer. Now, the answer for the above question, which I have asked, that beta blocker therapy after acute MI is contraindicated with of the following condition. Now, see, the beta blocker therapy actually in the acute condition we don't give in the heart failure. Okay, it worsens in the heart failure. Though in the prophylactic measure in the chronic condition we give, but in the acute condition it is contraindicated. And in the case of the orthostatic hypotension also we don't give. And in the case of peptic ulcer disease, that is out of the question, because peptic ulcer disease the beta blocker therapy is not warranted unless and until we give non-selective beta blocker. So that is also not given. And in bronchial asthma, that is also very much contraindicated because it can worsen the bronchial asthma. So the correct option for the above question is option A, that is heart failure, option B, that is orthostatic hypotension, and option D, which is the bronchial asthma. Now I am coming with the paper 2. Now, this is also a very important question. Just I am putting before you the question, and then I will be discussing about the answer. A 55, listen it carefully, it is a bit lengthy, not lengthy, but it is a bit 2 or 3 lines lengthy. A 55-year-old male came with a history of hoarseness of voice, for which the direct laryngoscopy was done, and the lesion was taken for biopsy to detect and it was detected as a SCC, squamous cell carcinoma. And he now recalls investigation to detect the extent of cartilage involvement, imaging of pre and paraglottic spaces, and extension to the deep neck structure. So, most appropriate investigation of choice will be what? Okay, I am repeating the question once again. A 55-year-old male came with a history of hoarseness of the voice, in which the direct laryngoscopy was done, and it was taken for the biopsy, and it was detected to be a squamous cell carcinoma. So, a further investigation is required to extend the cartilage involvement in imaging the pre and paraglottic space and any extension of deep neck structure to detect any metastasis or etc. So, the examiners want to ask, and the most appropriate investigation of choice will be what? It is a CT scan or endo ultrasound, MRI, or repeat direct laryngoscopy under G. So this is I think it is a bit easy question. It is given in the lengthy. So you think for a while, and then I will be coming with the answer after 5 to 10 seconds. Now, I think you have come for the answer. The 55-year-old man with a history of hoarseness of voice and direct laryngoscopy was done, and the reason why was biopsy to detect squamous cell carcinoma. It requires a deep investigation to extend the cartilage involvement and of the pre and paragangliotic space and any extension to the deep neck structure. Most investigation jobs. Now, after reading the after telling the question to you, what is the mind? Actually, the patient is suffering from what? The patient is actually suffering from CL larynx. Okay, as the question suggests, the patient 55-year-old patient with the CL larynx, and just I am giving you the brief because the epidemiology of the male female ratio is 10:1 because the male are most frequently involved, and investigation as far as concerned is firstly we do indirect laryngoscopy for the appearance to take the lesion and to take the biopsy and vocal cord morbidity, and in the case of the radiography we prefer to do the CT scan to find the extent of the tumor and invasion of the preglottic or paraglottic space, destruction of cartilage and cervical lymph node involvement, as I told you, to detect any metastasis or something like that. MRI is useful in the, I think MRI not so much useful in this stage because MRI is useful for the in the case of the recurrent cases after radiotherapy. If you give the new adjuvant radiotherapy, after that the extension of that is required. So the here the answer will be CT scan. Here the option I am giving, that is CT scan. I have not given you the option, sorry. It was the option A is CT scan, B is endo ultrasound, C is MRI, and D is the repeat direct laryngoscopy under the GA. So the option will be here CT scan. Uh, Now I am going to paper 6 again. Sorry, not paper 6, paper 1. Paper 2 I have developed. I have told paper 6 I am coming. Now this is also a very easy question. I think it is the question of medicine. Now listen the question carefully. Only one line question is there. Causes of hypomagnesemia, that is lower magnesium. Causes of hypomagnesemia include all of the following except, that is after the option which I will be giving, which option is wrong here. First is beta blocker therapy, B is chronic pancreatic insufficiency, C is the poor control diabetes mellitus, and D is alcoholism. So you think for the answer, you pause the video of mine and you think for the answer and you give. I'm giving you for this, I will be giving you only 5 to 6 seconds because it is a very easy question. So you think for a while and then I will be coming with you with the answer with explanation. Now, I'm coming with the answer. In the case of hypomagnesemia, the causes of the hypomagnesemia is here in the option 4, that is beta blocker therapy and chronic pancreatic insufficiency or poor control diabetic mellitus or alcoholism. The option is the main option. I think most of you have thought to correctly, I think, because it's a very easy question. Beta blocker therapy does not cause hypomagnesemia. Okay, and chronic pancreatic insufficiency do causes, because it causes chronic pancreatitis, and here the magnesium is depleted, because as the calcium is depleted with this, the magnesium also get depleted in the chronic pancreatitis. So in the case of chronic pancreatic insufficiency, the magnesium deficiency is inevitable. And in the case of the poorly controlled diabetes also, in the purely controlled diabetes also, the calcium is depleted, and because calcium and magnesium both come together as a jointly, so as calcium depletes, the magnesium is also get depleted. And in the chronic alcoholism also, as we all know, magnesium is depleted. So the answer here will be beta blocker, because all other options are true in hypomagnesemia. Beta blocker therapy does not cause any cause of hypomagnesemia. Now here again, paper 1 question, it is a very important question, so I am discussing here. Now the question is goes like that which one of the following is not a treatment of hepatic encephalopathy. This is a very important question. Hepatic encephalopathy, which is the not of the following treatment of the hepatic encephalopathy. Option A is lactulose, B is rifaximin, C is TIPS, that is transintracranial portoclonic shunt, and D is the electrolyte supplementation. So the not a treatment of hepatic encephalopathy is what? So you think for a while, then I will coming you with the answer. Now, I think you have got a thought for the answer. Which of the following is the not treatment of hepatic encephalopathy? Actually, firstly, just I am giving you the brief definition of hepatic encephalopathy. That is, what is hepatic encephalopathy? Hepatic encephalopathy is a disorder in which there is a failure of detox. It is actually the failure of detoxification of the nitrous agent by the liver, and the stages are mild confusion, drowsiness, coma, stupor, and the precipitating, what are the precipitating fetal stimulating factors are constipation, GI bleeding, alkalosis, potassium deficiency, and opioids also, and sedative hypnotic medication containing the ammonium compound. Paracentesis also causes hepatic encephalopathy, and apart from that, if you do the portosystemic shunts like TIPS, that also causes hepatic encephalopathy. And the treatment for the hepatic encephalopathy, we do protein restriction, and we have to control the GI bleed by the various methods. The gastroenterologist and the surgical gastroenterologist do it. Magnesium citrate we give with lactulose also, because but the function of the lactulose is the digested by the bacteria, and the colon is acidified, and formation of the non-absorbable ammonium ion by the ammonia. So the patient get relieved by the uses of lactulose. Antibiotic also we give, like rifaximin, metrotinozole, correction of zinc deficiency, lowering ammonia level. So these are the things used. So TIPS is very much contraindicated in the case of the hepatic encephalopathy. Now, again, paper one, this is also a very important question, a favorite question of me rather, because it was asked in in the 2012, even in the 2002, and in the case of the 2016 also it is asked. Now, features of intravascular hemolysis are the following except. Now, what are the features of intravascular hemolysis? Because there are two types of hemolysis, as we all know, extra and intra. So, what are the features of intravascular hemolysis? So, the features of intravascular hemolysis, option I am putting before you. Option A is increased LDH, B is hemoglobinuria, C is increased serum indirect bilirubin, and D is increased serum haptoglobin. So you think for the answer. I'm coming, because this is also an easy question. I'm coming with a 5 to 6 second again. Meanwhile, I am seeing the which question is asked very much, and which question is very much common to be asked, and that also only I have said that this also I am discussing with you. Now, I think you have come up to the answer. Intravascular hemolysis, the features of the intravascular hemolysis. Firstly, you have to think that what are the condition in which the intravascular hemolysis takes place. There are only few conditions in which the intravascular hemolysis takes place. Firstly, snake bite causes intravascular hemolysis. Then mismatched blood transfusion also causes intravascular hemolysis. So the features which are encountered in the case of the hepatic encephalopathy are the LDH has been increased. So option I have not given, or I think given, I forgot. Increased LDH, B is hemoglobinuria, and C is the increased serum indirect bilirubin, and D is the increased serum haptoglobin. Apart from of that, in haptoglobin levels is not increased, rather haptoglobin level is decreased because it mixes with the hemoglobin and with the free, because haptoglobin is the free levels of the hemoglobin. It combines with the hemoglobin and it comes out as a urine, as a hemoglobin urea. So haptoglobin level is not increased, rather it is decreased in the case of intravascular hemolysis. So this is the not a correct statement, and rest all are the correct statement, because all are the features of the intravascular hemolysis, like increased LDH, hemoglobin urea, and increased serum indirect bilirubin, not direct, because indirect bilirubin it is increased. Okay. Now I am coming with the paper 2. Now, this one question is a bit easy question, but a tricky question. First, listen the question, then you will think for the answer. And question goes like this: which of the following is or are the measures of dispersion? Okay, it is a question of SPM. So, and this question was, I think, asked many times in 2007, 2002, even in 1982 also, and it was asked in the it was asked in the 2017, I think. Yeah, it was asked in the 2017 and even in the 2019 also. So, which of the following is or are the measure of dispersion? Okay. So, the option A is mode, option B 2 is median, and option 3 is standard deviation. So, very easy question. Option the select the correct answer using the code given below. So they have given option A is 1 and 2, B is 3, C is 2 and 3, and D is 1, 2 and 3. So I think I will give you only 5 seconds to think for this, because it is a very easy dispersion method they are asking. So it is bit a easy question. Just a minute. So I think you have come for the answer, because in the mode, median is not a measure of dispersion. Only the measure of dispersion is the standard deviation, where we get the variability and we disperse and we see the measurement. So in the case this option mode in the given question, one is mode, two is median, and three is standard deviation. The option will be standard deviation. So this is the question. Now I am discussing with you the last question in this video, because I will be coming again with the paper 1 and paper 2 both discussion. So this is a very short type of video of the 36 to 40 minutes, and the question goes like this. This is the paper 1 only, and I think it is a question of medicine, and it is a question not of medicine, it is a question of pharmacology, then it is a question of medicine. Now listen the question very carefully. All of the following are LABA except, LABA means long acting beta 2 agonist. All of the following are long acting beta 2 agonists except, that is levosalbutamol, salmeterol, formoterol, or indacetrol. So you think for the answer. I am giving you the option once again: levosalbutamol, salmeterol, formoterol, and indacetrol. Which of the all of the following are the long-acting long-acting beta agonist except? So except one, all are the long-acting beta 2 agonist, and you have to find out the answer.